Okay, so just finishing up on this slide, these are the phases of normal swallowing. So the first, second, and third phase as you're watching that bolus move down the throat. In this situation, I really think that a video is worth a lot more than a stationary picture. So I will link a video for you guys, and that will probably help you a lot more as far as the review of this process. Okay, moving on here, back to my corner. The 4 stages of swallowing. There's an additional first kind of optional first phase, if you will, that we'll talk about, which is the anticipatory phase, and that's where you're anticipating the food that you're going to be enjoying. Then you'll see here the oral prep phase, then the oral or oral transport phase, the pharyngeal phase, and the esophageal phase. Okay, and they are named by exactly what they do, which is really great. So the oral prep, well, we'll move into it here. Okay, actually back up. So you're looking at the little yellow ball is your bolus of food. So that's after you have taken the bite of your peanut butter and jelly sandwich. It's in that prep stage. It's kind of you've bitten it off. You're moving it around in your mouth. It's forming with the saliva, getting to be the right texture. And then the oral transport is where it's moving towards the back of your throat. Then the pharyngeal phase moves down into the pharynx, then the esophageal phase into the esophagus. Okay, so not overcomplicated in that way so much. But here, so the anticipatory phase includes the variety of foods that have been offered. Are these your preferred foods? Are they not? Are you serving me chocolate cake that I like, or are you serving me broccoli, which not my favorite? Which actually broccoli's okay. I'm trying to think of something really bad. Cabbage. Ooh. So the variety of foods being offered, the presentation, does it look great? The seating and just the whole atmosphere of how we're doing in our position. So those are things that are helping you with the anticipation of food. Hopefully you guys have some kind of experience that you can relate to if you have worked really hard cooking something and you've smelled it cooking all day and you're getting excited for it, and then you taste it, and that's kind of like a long drawn out process. Or maybe you didn't cook it, but you have you didn't eat a big breakfast or a big lunch because you're gonna have your big favorite supper that afternoon. That's the anticipation part, okay? And our folks that we will be working with may miss out on this altogether, right? So that's an important part to remember. A very client centered part that we can miss is that anticipation of the food that they are going to be eating. Okay. Also, then moving into the oral prep. This is where we're talking about the first bite as the food enters your mouth. So you're chewing or the mastication process. Your lips, cheeks, tongue are helping to form that bolus. The saliva mixes with the food to start to soften it and get it to the correct texture. Okay. Okay, and then so from here, start to think about your lips, your cheek, your tongue to form a bolus. And you've got some experience in this, you've done this before, but now think about someone with asymmetrical lip closure. So look at this gentleman here. You can see that he has had a stroke and that the right side of his face has some facial drooping and some weakness there. So what do you think it's going to look like when you hand him a sandwich or a glass of water to try to drink? How would you expect his response to be when he starts to hold that cup up to his lips, if he's not going to have the control to form it around either the utensil correctly or the glass or cup that you're offering him? Okay, so even just getting it into his mouth successfully is going to be difficult and different than a normal. And then also, what would you expect as far as once it goes into his mouth? He doesn't have the muscle control to hold his face up on that side. So he's not going to have the cheek, the tongue movement, the lip, and all those normal aspects that we look for, right? So just based on just a physical observation of him, we can determine a lot of things about what we would expect to go on, right? All right, then moving into the oral, some people call it the oral transport or the oral and pharyngeal phases, okay? So the oral is when the tongue sends the bolus towards the pharynx. And something that I want you guys to think about here is is that it's voluntary. And so think about like the sensory impairment that could be occurring and how that might change if he's even able to determine, you've heard of food pocketing on the weaker side. Well, if he doesn't have the sensation on that side, he may not realize that there's food pocketing over there. He may not be able to feel it as well. Or even if he is able to feel it, he may not be able to lateralize his tongue to go over there, scoop it out, and get it back. Okay? So those are things to think about. Another thing to think about here is how we were talking about that it may take additional time to chew the foods, which would result in it would lead to decreased endurance, like if they're just becoming exhausted by the process. And then, like I said before, that could result in decreased oral intake and weight loss. Okay. All right, then I've also got a note here for you that says that coughing notes decreased airway protection during the swallow. So if they are coughing, they're trying to get air in, and that the airway protection has somehow been compromised during the swallow. Okay, so that's what the coughing is about. The pharyngeal phase of the swallow is it's where your voluntary and your first involuntary starts. Okay, so it needs to be rapid so that your breathing is not interrupted. Okay, and like I was saying, that's where your coughing comes in, is if they're not able to successfully just go ahead and fluidly swallow. If something goes wrong in there, then their airway is compromised and they're not able to continue to breathe as normally as they should be able to. Okay, moving into that final phase is the esophageal phase. And this is where the esophagus, the bolus enters the esophagus, which is the tube connecting the pharynx to the stomach. Okay, and so it's important to remember here before we move on that the term dysphagia can denote a problem in any of these stages. Okay, and so that's where the more skilled assessment is going to help you determine where, in which one of these phases is our difficulty coming. Okay, moving into aspiration. Aspiration is something that you would want to see and look for beginning on your chart review. You're going to want to see if this patient has a history of being dehydrated. Do they have decreased weight? Do they have CHF, COPD? Do they need increased suctioning? Are they on multiple medications? Are they on a modified thickened liquid or modified diet? Do they have an NG tube or a G tube placed? These are all things that are going to start to tip you off to maybe this person would have trouble with aspiration. The thing about aspiration is that it is when a person is swallowing and the food enters the airway instead of proceeding down into their stomach, as it should. Okay, so you basically have a food particle of some sort that has gone rogue and gone down into their lungs. And when you get a foreign body down into your lungs, it can set up an infection, and then you can have pneumonia that occurs. Aspiration pneumonia is very serious. It's one of the biggest things I think that would cause one of the leading causes of death that people don't even think about or don't know about. And so it's identified by x-ray, and then it's treated with antibiotics because it is a form of pneumonia. But the thing that I want you to focus on here is where it says it can be silent, because folks think that if they're chewing but they're not coughing, then they're fine. Not true. Okay, so you can have silent aspiration pneumonia, and they can be aspirating those particles over into their lung and not even know. And that's why it's so risky, and that's why we need to make sure that they are following the precautions that are recommended. And so this is where you'll see folks that are on maybe a modified, so say that it's been recommended for them that they be on a thickened liquid diet. And let's say our client is crotchety old man, you know that they're my favorite, and we tell him that he needs to be on honey thick liquids, and that's really all that's safe for him to swallow. But you show him that he can have this thickener, and he can even mix it in his coffee because he tells you that he has to have his coffee every morning. Well, he doesn't like the way that thickener tastes. It messes up the flavor in his coffee, and he doesn't like it, and he's just not having it. This is when his very well-meaning wife may come in and say, Well, I just gave him a little sip of his favorite coffee just so he could have just a little bit, and he didn't choke at all, so he's been drinking it all week and he's fine with it. That's when, well, actually, before that is when you would have wanted to warn them about the dangers of silent aspiration and why, and the why behind what you're prescribing. Okay. So we'll also talk about some compensatory strategies to help improve the quality of that swallow. And those are going to be things like their positioning and the texture of the foods that you're going to recommend. Okay. All right. So aspiration, what it's going to look like, maybe some of these things, right? So a change in the client's color, and that may be that they turn red. If their airway is obstructed, they may even start to turn blue. That's not good. But you'll see that they'll get real, sometimes they get real flushed. You've seen when somebody is aspirated. You've aspirated yourself, okay? So it's the prolonged coughing and choking. Sometimes they get the gurgling voice or extreme breathiness and loss of voice. Usually your eyes will start to water and you're thinking, I wish I could just get it together. And that's what that's about, okay? So that's considered aspiration. All right, now moving into positioning. There is no good place to put myself in this slide. How about there? So this is very OT, okay? So we talked about that a lot of these areas are kind of a overlap of OT and speech and who does what. This is probably going to be a mix of you and the PT, maybe even working together to come up with the best position. But on this slide specifically, I wanted to kind of look at it and say, what do you guys think about these positions? Which ones are preferred for feeding? What is a good position for swallowing? And so without any other background information, you would assume that this lady in the top here, that she's probably not in a great position. Number one, she's asleep, so that's not good. She's not as alert as she should be. But then she's also slumped over, even from her hips, her trunk, on up to her shoulders, her C-spine, and she's got that lateral flexion going on. Okay, so if I were to come and work with her and try to wake her up for a meal, I would try to start with her hips and try to get her back in a little bit more alignment. I would then come up to her waist and try to see if we could maybe get some pillows if she doesn't have the trunk control to sustain that upright posture. Because remember, these folks have had some kind of neurological deficit. They've had some kind of insult usually. So maybe she can't sustain that. Maybe we need to prop her with a pillow. But so we look at her and we think, yeah, that's probably not great. Then we look over at the guy that's in the hospital bed, okay, and he's sitting upright. Is he too far upright? What do you guys think about that? Should he be allowed to eat in bed? Then we have the little girl feeding grandma, okay, and what do you all think there? The thing that I'll point out to you here is that she is smaller than grandma, okay, so she's at a lower height. Notice grandma's chin is slightly back, so because she's looking down. So we'll talk about that as well, but that's one that I'm going to be okay with. Okay, so I'll just go ahead and spoiler alert there. The next one is a guy down at a table. He's at 90 and 90, and we think that probably looks pretty safe and pretty good, right? Then we've got our guy who's been binge watching. He's rocked back at like 20 to 30 degrees supine, and we're going to say that's probably not good. He also looks like he's eating some ice cream and some popcorn at the same time. Popcorn is a big choking. It's kind of like not a great food because of all the loose holes and particles. So in addition to poor positioning, popcorn's probably not a great food for him to be eating. Then we've got the fellow that's laid back in the hospital bed as well. So we're going to look at the next slide then and move on and say for positioning, the please do's. Please do. So 90-90, so meaning hips should be at 90 degrees and knees if able. But having them as close to upright as possible is going to be good. Getting their arms to be supported and having a firm either a lap tray on their wheelchair or a table surface that they can use for arm support if they need that. And then you see my don't you dares, right? So there are always times that we have to make do. But if at all possible, try to get the patient's head of that bed up. So times when it wouldn't be okay to get the patient's head of the bed,